Hello, everyone. Thank you for joining us today for our webinar entitled Understanding and Implementing Chronic Care Management in Your Practice. Today's presenters are Latia Darrington, Alterum's Care Manager, and Laura Haberly, MCEDA's Commercial Services Program Manager. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Latia or Laura, please type it into the questions box in your GoToWebinar interface. We will take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's webinar and a copy of the presentation slides on our website, mceda.org. Go to www.mceda.org. Hover on the Resources tab, then select Webinars. The information presented in this webinar is current as of today and is only intended to be a general summary. As policies change frequently, the best way to stay up to date on current requirements is to review the actual written law or regulations. We encourage participants to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their content. Today we will begin by giving you an overview of chronic care management, its eligibility requirements, and how to implement these services into your practice. Following the presentation, Latia and Laura will take time to answer any questions posed by the attendees. With that, I will turn things over to Latia.
Thank you, Liz. Good afternoon, and thank you all for joining today. As Liz stated, my name is Latia Darrington, and I will be going over what chronic care management is and the changes of the calendar year 2017. Later in the presentation, I will be joined by Laura, our Commercial Service Program Manager, who will explain how to implement CCM into your practice. The Centers for Medicare and Medicaid Services recognizes CCM as a vital component of primary care. In 2015, Medicare began paying separately under the Medicare Physician Fee Schedule using CPT code 99490 for CCM services furnished to Medicare patients with multiple chronic conditions. Chronic conditions account for 84% of national health care spending. 2/3 of Medicare beneficiaries have 2 or more chronic conditions. In 2017, Medicare added 3 new billing codes, 99487, 99489, and G0506. So what is CCM? Chronic care management, better known as CCM, are services provided by a physician or non-physician practitioner per calendar month. These services are geared towards Medicare patients with multiple 2 or more chronic conditions expected to last 12 months or until death, and that place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. This diagram gives a high-level overview of CCM and the billing. G0506 is a new code as of 2017. In order to bill this code, the eligible practitioner must personally perform an extensive assessment. At that time, a care plan is developed, then shared with the patient, and verbal consent is obtained. This code can only be billed at the time of consent once per year. A care manager follows up monthly with the patient via phone call to review the care plan. The physician can also bill for this service. Our next slide is a continuation and breakdown of other billable codes and their uses. Non-complex code 99490, which is defined as non-face-to-face care coordination services provided to Medicare beneficiaries, consisting of at least 20 minutes of clinical staff time directed by a physician or other qualified healthcare professional per calendar month. These services may be provided directly by the eligible practitioner, by consultants subject to Medicare's physician fee schedule, incident to rules and regulations and all other Medicare rules, or by the clinical staff incident to the billing practitioner. Complex code 99487 is also defined as non-face-to-face care coordination services as of 2017, provided to Medicare beneficiaries. To bill the code, at least 60 minutes of clinical staff time or other qualified healthcare professional must be performed. They must also establish or substantially revise the care plan. In conjunction with Complex Code 99487 and only 99487, any additional 30-plus minutes spent is eligible to be billed using Code 99489. This code was also introduced as of 2017. The intent of CCM is to have the primary care coordinate patients' care. However, the code allows for most providers and practitioners to bill for this service, including specialists. The billing provider must oversee CCM service. However, they are not required to be present for the work to be done. Here is a breakdown of payment for each code. G0506 is about $64 and again can only be billed once a year per patient at the time of consent. 99490 is about $43 and can be billed per patient per month. 99487 is about $94 per patient per month, and 99489 is about $47 per patient per month, in addition to the $94 when being billed with 99487. Again, keep in mind 99489 can only be billed with 99487 when 30 minutes or more has been performed along with the 60 minutes needed to bill 99487. All slides will be available on our MCEDA webpage. So who's eligible to perform CCM? CMS allows physicians, physician assistants, clinical nurse specialists, nurse practitioners, certified nurse midwives, certified medical assistants, as well as FQHCs and RHCs. I will go into further detail about FQHCs and RHCs in my next slide. Unfortunately, CMS does not allow limited licensed physicians and practitioners such as clinical psychologists, podiatrists, or dentists to bill for CCM. Please see CMS website, which will be provided for further details. Although FQHCs and RHCs are able to participate in the CCM service, they are unable to bill for the new codes established in 2017, which are G0506, 99487, and 99489. However, FQHCs and RHCs can receive payment for CCM when billing code 99490 alone or with other payable services on an FQHC or RHC claim. When billing 99490, the provider must personally perform an extensive assessment and CCM care planning beyond the usual effort described by the separately billable CCM initiating visit. Eligible patients must be Medicare beneficiaries with 2 or more chronic conditions which place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline, and are expected to last at least 12 months or until death of the patient. They must not have other diagnostic limitations such as ESRD, which is end-stage renal disease, and again, everything will be explained by the CMS resource at the end of the presentation. In order to bill CCM, providers or practitioners must get a patient's consent, either verbal as of 2017 or written during a comprehensive or annual wellness visit. Upon consenting, it is the job of the billing provider or practitioner to inform the patient that the care plan will be shared among all of the patient's providers as needed. Once the consent is signed or given as a verbal, it must be stored or documented in the patient's medical record. If a patient chooses to revoke consent, providers may not bill for CCM after the month the revocation was made. If the CCM service has already been completed, providers may bill for that month. The patient can terminate the CCM service by revoking consent. The patient will be responsible for any associated copayment or deductibles not covered by any other insurances the patient may have, and only one provider can provide CCM services at that time. My next slide will explain what a consent should consist of. Eligible practitioners should explain what chronic care management services entail and offer these services to the patient, document the discussion in the patient's medical record, noting the patient's decision to accept or decline the services, or obtain written agreement to have the services provided. The agreement should include authorization for the electronic communication of medical information with external members of the patient care team, and lastly, explain how to revoke or terminate the services. The chronic care management service is extensive and includes elements such as structured recording of patient health information, creating and maintaining an electronic comprehensive care plan, ensuring access to and continuity of care, and care management services. CMS requires the use of a certified EHR in order to satisfy some of the chronic care management scope of service elements. I will break down the elements in the next few slides. The structured data recording requirement of the chronic care management scope of service dictates the use of certified EHR technology to record patient demographics, problem lists, medication lists, and medication allergies in order to create structured clinical summary records from the EHR. The care plan scope of service element requires a comprehensive care plan to be created, maintained, and available electronically at all times to anyone within the practice providing chronic care management services. The care plan should be provided electronically other than by fax, as appropriate to external providers and practitioners, and the patient must be provided with either a written or electronic copy of the care plan. A comprehensive care plan typically includes a problem list, expected outcome and prognosis, measurable treatment goals, symptom management, plan interventions, and identification of the individuals responsible for each intervention, medication management, community and social services ordered, description of how external agencies and specialists will be directed or coordinated, and schedule for periodic review and, when applicable, revision of the care plan. Ensuring access to care by providing the patient with a means to make timely contact with healthcare practitioners within the practice who have access to the patient's electronic care plan. Addressing his or her urgent chronic care needs is also a scope of service element. Additionally, continuity of care and enhanced communication opportunities for the patient and any caregiver with the practitioner in compliance with HIPAA must be provided. At this time, I will turn it over to Laura, who will go into the implementing of CCM into your practice.
Good afternoon. My name is Laura Haberly, and I am MCEDA's Commercial Services Program Manager. In my 6 years with MCEDA, we've seen the benefit of many of our various service offerings, like chronic care management, help support success in our providers' offices. According to the MGMA Cost and Revenue Survey of 2015, a primary care provider sees between 172 to 345 Medicare patients that met the criteria for chronic care management. The problem that our providers were experiencing was the amount of time that it took to perform these services in-house. Our diagram shown is a breakdown of the time constraint if this were to be provided in-house. Our goal is to provide technical assistance to alleviate this practice problem. CCM is a new service offering here at MCEDA. We are currently educating providers on how, with the help of our chronic care management team, this could close the gap in care and generate more revenue for the provider. Providers who have implemented the program have seen increased patient satisfaction, as well as a 20% decrease in back-to-back ER visits from the patient. Our CCM service offering provides a staffing solution for your office. We will evaluate your need based on patient volume and develop a schedule and workflow for CCM services in your office. This includes a communication, recruitment, and EHR access plans. Once patient recruitment begins, your MCEDA chronic care management will begin to call and review patient care plans directly with your enrolled patients. These services can be delivered on-site or remote depending on your office's needs. Here is a brief overview of revenue generated by providers billing for non-complex care over 12 months. Please note that this does not include an estimation for the G code used to set up care plans during the patient visit or complex care. These will also have a positive impact on your revenue. If you are interested in hearing more, we would be happy to put together a custom estimate of revenue and what our services would cost. Pricing is custom for each practice based on need and volume, and we are currently offering discounts on the service. Please let us know if you'd be interested in hearing more. As promised, here is our chronic care management resources list for you to review on as you see fit. And again, all of your slides that we've presented today will be available on our MCEDA website. Okay, we are going to take questions at this time. If anyone has a question for Latia or Laura, please type it into the questions box in your GoToWebinar interface. We have had a few questions come in during the presentation. The first one is, can two physicians bill for chronic care management services for an individual patient?
Great question. No, only one physician can bill for the CCM service during that month.
What are patient eligibility requirements for CCM services?
A patient must be a Medicare beneficiary with 2 or more chronic conditions expected to last a year or until their death and place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline.
Can I bill for CCM services the same month I bill a transitional care code?
Unfortunately, no. Medicare does not allow for a transitional care code and a CCM code to be performed the same month, but CCM services are able to be resumed that following month.
Okay. That is actually all of the questions that we have for now. If we missed anyone's questions, we will email you directly with an answer shortly. As a reminder, we will be posting a recording of today's webinar and a copy of the presentation slides on the MCEDA website, www.mceda.org. Thank you, everyone, for attending, and have a great day.